our teaching session. And thank you very much for this presentation. I think it's really difficult to manage this patient before and after surgery, especially after our unifocalization. So could you tell us, please, a bit of management in ICU before and after surgery for this group of patients?
Thanks, Oleg. Kind of not disclosure, but confessions. I'm not very good with these Teams and Microsoft Teams. So if I make mistake and do something, let me know. We'll make it work slowly and steadily. So I think we have done cardiology part and we've done surgical part. Today we are going to focus on the ICU and how frequently they visit and what problems and challenges we face. Um, let's go through this one. Just a little bit simple background to start with, so that we can have a bit of a year 1 and 2. So it's a pulmonary atresia VSD is an extreme form of tetralogy of Fallot. So Fallot means there is a VSD, aorta is malpositions, extreme form of RVOT obstruction. So there is pulmonary atresia. You will invariably find RV hypertrophy, and that becomes a very important and kind of a bottleneck for post-operative management of these patients. Biggest problem is the pulmonary atresia and what happens, what is in the pulmonary tree ahead of the pulmonary wall. So that really defines the course of patient recovery pathway. It could be membranous atresia or complete pulmonary atresia where there is a native PA or a main pulmonary artery is not present at all. And there can be extreme variability and or in the presentation of what are the main pulmonary artery, branch pulmonary arteries. Before we go on to that one, this is more for ICU part of it. Is very important to understand that pulmonary atresia with VSD and pulmonary atresia without VSD, they are completely different conditions. They are differently patients and different pathways. Uh, Reading through and learning through, my thought process has been whenever the VSD is there associated with pulmonary atresia, most of the, or rather problems are beyond the pulmonary wall. So you will have a tricuspid wall which is normal. Um, ASD is irrelevant in them. RV pressure is going to be equal to the left ventricular pressure. You won't find any sinusoids, coronary sinusoids from RV whenever the VSD is there. Obviously, pulmonary atresia, so your lung perfusion, pulmonary perfusion will be dependent on the some sort of a shunt, or that will be ductus in the neonatal period. And ultimately, they should progress. And most of them, they do progress onto a biventricular repair. But as opposed to that one, when you look at pulmonary atresia without VSD, it's completely more sinister group of patients. But their pulmonary arteries may be pretty okay. Like they could be okay, like the native PA and branch PAs may be okay. But the whole problems are below the pulmonary wall. So tricuspid wall will be bad, stenotic, regurgitant. ASD is necessary for life, intratracheal communication. So because it's a closed compartment in a RV, there is a pressure in the RV is going to be high, then you are likely or you are at risk of having RV to coronary sinusoid, very dangerous anatomy, pathophysiology there. Obviously, again, pulmonary atresia, so you need ductus-dependent pulmonary flow neonatal period, and then we will intervene. And patients without VSD in a pulmonary atresia patients, they have a Fontan future. So it's a single ventricle pathway. This is how I have put those things together. And today our focus is pulmonary atresia with VSD and how do they progress and what do they, how do they behave in ICU. Is that okay? If I'm not clear or something, just this is interesting because I don't get interaction between the people. So just be loud and clear to pause me and we can have more discussion about the point. How I've worked around this is I've selected, these are our patients in last 5-10 years, few patients, and then I've tried to put them into group and walk through these patients, and then we go through their ICU pathway and their overall outcome. So this patient is Maya. So she was born in September 2018, and she had an antenatal diagnosis of pulmonary atresia with VSD, and there were no MAPCAs. So no MAPCAs. The first patient without any MAPCAs. I'm sure we've revised this one before with the surgical anatomy and surgical aspect, that pretty much three groups or three categories of these patients where there are no MAPCAs. Then the pulmonary or QP is dependent on MAPCAs, native pulmonary artery plus MAPCAs. And then the worst part, or category C, as it gets called in the surgical classification, where there is no native PA, and everything is dependent on MAPCAs. So we will have a few patients like that. So starting with simple asset in terms of pathology, patients are complicated. No MAPCAs. So these patients, commonly, most of these patients will have, at least in this setup, antenatal diagnosis. They're usually born induced at term time, so reasonable body weight, roughly 3 kilos at birth. And with the antenatal diagnosis, they would be started on prostatin infusion. They should be self-ventilating, and they come across to cardiology ward. And that's the pathway for a pulmonary atresia, VSD, no other problems or complications on prostatin, and they should come to ward unless there is a added complication. So preoperative workup. So this if you like, this is pre-op course for this patient. So this kitty antenatal diagnosis, born in good condition, now is on day 2, is already in Alderhay on a cardiology ward. Echocardiogram has been done to confirm the diagnosis, and then there is a further cardiac workups been done to assess what exactly is happening with this duct, what is happening with the PAs. But in this patient, in Maya, the ductus was quite tortuous and not suitable for stenting. So no sizable collaterals there. So that's another thing to kind of clarify the anatomy. This patient had a modified BT shunt and a PDA ligated. So this patient has moved from a PDA ductus dependent to a systemic to pulmonary shunt in the form of BT shunt. So let's see what happens in ICU. So from pre-operative course for this patient, now this patient is moved into ICU. So this neonate, during the neonatal period and the first phase with the BT shunt, this patient stayed in ICU for 13 days. On the post-operative day and onwards, there were concerns that the ongoing concerns about hypoxia and ventilated. We will do usual normal thing to make sure that we are ventilating patient fine, going on to nitric, and making sure that there is enough systolic blood pressure or driving pressure so that QP is adequate. Having done all those things and investigated this patient, but hypoxia has persisted. So then we need to rule out the anatomical causes or clarify the anatomy again. That's why patient had a cardiac CT done. So in terms of if you have a persistent hypoxia, and we'll talk through one of the flow charts which I've done, a cardiac CT which showed, well, the anatomy is very good. It's more like a functional obstruction. So started on sildenafil, moved on fairly quickly, extubated on day 11 post-operatively, and day 13 was discharged to cardiology ward. So this patient, it won't be a surprise in the neonatal period if these patients perioperatively have a hypoxia, and that's kind of one of my discussion point with this patient with this episode, and we'll look into that a bit further. But so by within 2 weeks time, this patient is back to cardiology ward, now having had a BT shunt, standard aspirin anticoagulation, and would move further in life. So this is talking about hypoxia in these patients, or any patient where you are questioning the pulmonary blood flow or balancing circulation. This is it's a standard pathway. I've just tried to put it my way into the slides, and let me know if you need any question, clarification, or if you think there is something more addition to add on to this one. So whenever there is a patient with hypoxia, I would try and see is the air flowing into the lungs well. So let's sort that one first. So lung and pulmonary causes. If there is a lung cause, then pulmonary venous desaturation, which comes to heart, then you have a systemic venous desaturation or systemic desaturation, if that makes sense. So pulmonary venous desaturation, work on that one, that you've got that one absolutely right. So appropriate size tube in good position, ventilation is appropriate, there's no pneumonia, there's no effusion, there's no hemothorax. Get those things sorted, starting with the tube, breathing tube, ET tube in a good position, to lung parenchymal causes, to pleural causes, to ventilation causes. So that I would just put down as a ventilation, even correctly, is the causes of pulmonary venous desaturation. Once you've done those things, then you go on to more important cause, which everybody would directly jump onto, is have I got enough pulmonary blood flow in this patient, because that's what we have intervened for. So let's look into pulmonary blood flow QP. And that could be because of two reasons, because the anatomy, that the pathway is not very clear or smooth or obstructed, or the pathway is very clear, but it is functional, i.e. the pressure on the other side is very high, and that's why there's no delta for blood to flow across, if that makes sense. And I think in Maya, that's what we documented with doing a CT, cardiac CT, making sure the shunt is right size, appropriate, well placed, no kink, no obstruction. Then we said, oh no, this is more functional or a medical causes. So pulmonary vascular resistance has not settled down or is taking time for whatever the reason, neonate, PPHN, pulmonary hypertension. I've said pulmonary hypertension because this would come back again in an older child as well. If the PVR is high, then no delta, and we will not have enough pulmonary blood flow. We will have desaturated patients. And we need to be certain about the anatomy and a pathway and a plumbing. Part of it would be in our hand, or rather surgeon's hand, that okay, we can go across and sort out a BT shunt or pulmonary arteries or branch pulmonary arteries, but sometimes they are so small and restrictive, i.e. you can go up till hilum and do hilum to hilum, nice enlargement and plasty, PA plasty done. But beyond that, the road may still be very small and we may not be able to sort that one. So that's a challenge. Obviously, we will make certain that shunt is patent and there's no kink and no problem, and that there could be another way of shunting, which will come to another patient, where RV to PA conduit is there, and if there is an obstruction, kink, anastomosis. So these are the common approaches. Other thing would be, these are the mixing patient, and you need to have more red cells and RBCs and hemoglobin to perfuse the tissues adequately. So anemia is another. So I've gone to the third limb of this. Anemia or sepsis, and you have a systemic hypotension. So whenever a pulmonary blood flow is dependent upon systemic systolic blood pressure, so driving pressure, so we have to make sure that there is adequate. If the shunt size is okay, then we make sure that the perfusion pressure for QPs is okay. Okay to move on? Yeah, I'll move on.
Yeah, that's fine.
Thanks. So because we were talking about this, so this could be the emergency in these patients, not only in the post-operative period, but while they have the BT shunt, i.e. there is only one road for this QP and pulmonary blood flow, and we have to keep it patent. So how do they present? Maybe post-operatively, or if it is even difficult, challenging, it may be at home, and they have a sudden profound desaturation. If you are there very quickly, or i.e. it's in a or still on the ward, then you will have near normal hemodynamics to start with before you lose everything. We always emphasize when these patients come to ICU in an immediate post-operative period, that we make sure that whoever is the red, whoever is the medical team, we listen to the murmur which is there because of the BT shunt. We can cheat the system, because if we listen to with the bell of the stethoscope onto the ET tube, it gives you a beautiful murmur, and that's easy. Obviously, when the patient goes to ward, you have to be certain that, okay, where am I listening? What am I listening to? But you will not hear the murmur. So listening to the murmur in the immediate post-operative period and making sure that, okay, your eyes and ears are tuned to that one is very important. Chest will be clear, so you're able to move the chest very quickly, easily, not much pressure, but you're not having any result with improving saturations. In this case, this is clinical emergency, my standard approach for emergency medicine or intensive care would be give the fluid bolus, fluid resuscitation, increase your driving systolic blood pressure, give inotropic vasoconstrictor support. Heparin bolus, if there is enough concern about this one obstruction, I would be very, I won't be reluctant to give a heparin bolus and get a echocardiographic assessment, and we need a surgeon here. So these things need to be done very, very quickly, and emergency things. So this is a cardiac surgical emergency. There's no way you can fix it. What you need to do is think about it, identify it, flag it up, and make sure that this patient is in cardiac surgical hand very quickly. So in terms of hypoxia, this is an ongoing hypoxia in a post-operative or any patient with a shunt. I would approach it that way, and a crisis desaturation. That there's a block BT. I would put a BT shunt, but block shunt. That's what I would go across. So one of the biggest theme for these patient would be hypoxia, and that's how I would approach it. Okay. Moving on, in the neonatal period, you're from moving on from desaturation to hypersaturation or overcirculation. BT shunt or a central shunt or any kind of a shunt where you may have now. Let me phrase it again. So if the pulmonary vascular resistance has already settled down, then your pulmonary blood flow is pretty much dependent on what the size of the shunt is, place of the shunt is, how proximal, how distal it is, and if there is any additional pulmonary blood flow from collaterals or MAPCAs or something. So that is also important. Critically important in a single ventricle pathway may not be that, and it could be tolerated in a biventricular circulation, but it is still important that we don't flood the lungs and move from a restricted pulmonary blood flow setting to flooding of the lungs and excessive pulmonary blood flow setting, which will come and bite us in future. So very important to keep and balance the circulation. I'm sure that whenever we talk about single ventricle pathway, this will be discussed, and that becomes the theme of balancing the circulation. So that's one of the important themes, that, okay, don't give excess oxygen. Major aortopulmonary collateral arteries, and if that could be another source of a QP. How do you manage it? Okay, you can ventilate or not ventilate adequately and increase the pulmonary vascular resistance. And try and see if the circulation stabilizes. But sometimes you need to go and intervene if there is a persistent high QP. Okay, this is less of a problem with this this circulation, more of a problem in a single ventricle pathway. Okay, so this was a neonatal period for Maya. So now we have a patient with pulmonary atresia, VSD. I've put MAPCAs as a diagnosis, but I don't know why that came. And I had a previous BT shunt there. Now she's come at 1 year of age with a corazal, cough and cold kind of symptoms, and she's desaturated, and saturations are in 50s. They have gradually improved to 70s, and she's now settled on Optiflow on HDU, but she's in a pretty significant oxygen requirement there. So she had further investigations done, CT which showed irregular RPA, but good size. So the plan is to go ahead and do a full repair. So a VSD closure, RVT peg, and take down of the BT shunt. So I come to post-operative care. So this would be kind of a pre-operative part where treat it as a hypoxia, make sure the shunt is patent, you've done everything, patient's not dehydrated, everything. And now we have moved on to a post-operative care of this patient. Now this patient has had a full repair done. So what happened? So this patient is done pretty reasonable, just 5 days of ICU course after this repair, which is pretty good. But child's kind of 1 year old now, a bigger child, a little bit. So chest came in with the chest open. Standard issues, post-operative issues will be bleeding, cyanotic patients with a kind of impaired platelet functions, pre-operative antiplatelet agents, hypoxia that can lead to more bleeding. So cyanotic patients are always predisposed to bleeding, so that will be a standard thing, and you need to work around it. Initial stabilization with inotropic vasoactive support. Day 2, pretty good, steady chest close. So delayed chest closure. This is not delayed, planned chest closure. Stable hemodynamics. It's been fluid responsiveness, and we'll come to fluid responsiveness a bit further and in detail when we talk about diastolic dysfunction and hypertrophic RV. Which patient was progressing very well. Day 3, so this is 1 year old, and this child has already had a full repair done. So that's how I'm thinking. Day 4, chest drains have been removed, extubated, commenced on aspirin. PD still in place, but it is clamped, and then now patient is discharged to ward on milrinone and on pacing. Looking at this patient's last follow-up, so September, so she's 14-month-old, 9.7, 76 centimeters. So in terms of pediatricians and things, this is pretty good result in terms of how the weight is, how the length is, and child is doing well. So this first patient was more about pulmonary atresia, VSD with no MAPCAs, and that's how the patient progressed. And by first birthday, 1 year of age, patient has been anatomically sorted, will need some more revision of the RV2P conduit and things, but is doing well with normal biventricular physiology. Okay. So this is the next patient, is Suleika. So she was born in August 2016, and she had antenatal diagnosis of tetralogy of Fallot with pulmonary atresia, born at term and 2.7 kilo. Born in good condition, started on prostin, saturating a little bit high in air. So a standard pathway in an immediate neonatal period, and came in on day 16 of life for right-sided modified BT shunt, LPA plasty, and occlusion of PDA chest and chest was closed. PICU stay was 6 days and uneventful recovery to be transferred to cardiology ward. So if you look at it, first patient, we spoke about Maya, and now this is Suleika. Pretty similar, but I would highlight, like as an intensivist who would try and look for kind of a small things to see, oh, this is not standard thing. This patient has already had an LPA plasty, not unusual from surgeon's perspective, but I would say, okay, that means the native PA was small and we may have plastied on the left side, but I'm thinking distally the road may be narrow or may not be, but I would look into that one or think that way. So after 6 days, patient is recovered and has gone to cardiology ward. And things didn't go right, though immediate post-operative period has been very quick to go to ward, acute desaturation, hypoxia, bradycardia on the cardiology ward, and this patient landed on the ECMO, arrest, ECPR ECMO, and was supported with ECMO for 6 days. So obviously going through, making sure the anatomy was fine, the BT shunt looks okay, the LPA looks pretty good as well. But then things were pretty grim in terms of organ injury, needed renal replacement therapy and continued on PD. Also had a right-sided infarct and a seizures and stayed in ICU for 24 days. So length of stay was 24 days with this episode and was discharged to HDU. So this is how any setback can send this patient back way further, and organ injury could be lasting, i.e. this is right-sided infarct and seizures, so there is a significant neuro event. It still made progress to move forward. While we are here and we are talking about ECPR ECMO, so I was to just touch base about ECMO and a physiology of BT shunt. So it's a little different and additional, and there will be, because you have to think there is a systemic blood flow and then there is a pulmonary blood flow coming out of the systemic artery. So there are, as such, if not one, there are 2 circulations going on, and ECMO has to support both of them. At the same time, you don't want to flood the lungs through this BT shunt and have a white out of the lung and then the lungs are back. So 2 things which I would consider looking after these patients on ECMO is make sure that you are ventilating these patients well. So not only the rest ventilation, but ventilate them a bit more. Otherwise, we will just cause lungs to get flooded with this BT shunt being patent. Another thing would be, which there is a lot of debate and thought about it, and should we clip the BT shunt or should we not clip the BT shunt? We just have to make certain as a team that there is enough cardiac output from ECMO or in total that we are able to manage circulating both the loops, systemic circulation, pulmonary circulation. There is adequate end organ perfusion, including coronary, including the cerebral perfusion. So these are the two aspects about ECMO and on with a patient who added a BT shunt or a systemic to pulmonary shunt. That's the ICU aspect about it. Moving on. Hey, this team's really I don't, because I don't see you guys. I don't have any feedback about it at all. Is this going okay? Am I going too fast? Am I going too slow? And you guys are too ahead?
Yeah, I think you're doing really well. Actually, you are all we are all impressing us.
Doing fine, Anand.
Okay. Cheers. Maybe I'm not doing that well with time. Okay. So this is Suleika. She went to HDU, and long story short, she had another similar episode, and she didn't respond, and then she died at 7 weeks of age. There was no appetite from family. Rather, they didn't want it to pursue further investigation. So we will never know. We have had a documented CT which shows that the anatomy was pretty okay. Though anatomy was okay, when it comes to functional and physiology or a pathophysiology, it wasn't. A patient who had a 2 cardiac arrest, end organ injury, there was something more happening. But you will, this is medicine. We will not have all the answers all the time, every time we want. So go back. So this is a second patient, very similar anatomy, a little smaller, 2.7 kilo, a little different LPA plus T done, but the outcome is completely different. But I think as a team, we did pretty well to kind of pull this patient through P and post-operatively. Okay, moving on to the third patient, which is Jasper. Jasper was born in January 20, so no, he's still a little baby. Again, antenatal diagnosis, pulmonary atresia with VSD, extreme form of fallow with a small confluent PAs, multiple MAPCAs. The third patient, I've gone MAPCAs, so left-sided subaortic, large subaortic VSD with more tissues around that one, and left-sided aortic arch, no coarctation. So this is a bit more, it starts to get a bit more complicated, a bit more spicy. 38 weeks, good weight, standard thing, start on prostin, come to Alder, self-ventilating in air, and then go to cardiology ward, do a CT or do a diagnostic catheter and move forward. This patient had a diagnostic catheter and an intervention at the same time, had an RVOT stent put in, made very good quick recovery. I think stayed in ICU for just overnight. I didn't even get that from the whole discharge summary thing. And on the follow-up in April, 3.5 months of age, saturating 84 in air, gaining weight, doing well. So this is pulmonary atresia VSD with MAPCAs, who has been investigated and intervened in the form of RVOT stent and is doing well. And we need to keep following this one. So that's the third patient, and third thing to talk about is how do we establish the pulmonary blood flow. And in the neonatal period, we saw BT shunt, or there could be extremely challenging shunts depending upon what the anatomy is. Another way could be RVOT stent. And that would be more of a invest echo, CT, and cardiac catheter, and that's how you would perceive cardiology, cardiac surgical team, like which patients, if you see a native PA which is reasonable size and a native branch pulmonary arteries, if they are of a good size, then would you opt for a stenting? How do you decide? Are you with me, Joyce?
Anand. So for children with an RVOT that is still patent for very tight tetralogy of fallow, to the point of close to pulmonary atresia, a lot of it depends on the suitability of the ducts versus the RVOT. So that comes from anatomy, either for echo plus minus CT, as well as the prevailing sort of expertise as well. So you might have seen that in more recent times, we have been doing, as in the last 3-4 months, we've been doing more RVOT stenting as compared to PDA stenting. It's not just a fluke that has happened. It's also because of the anatomy as well. When you have more than one twirl of the PDA, a very tortuous PDA, then you wouldn't want to go in to put a PDA stent. And fortunately, we have been able to do more RVOT stents because we have the expertise as well. Previously, if that weren't the case, then if there's one twirl, there is less expertise for RVOT stent, then we would have gone for a BT shunt.
Okay, thanks, Joyce.
Okay.
I'll move on. So this is my next patient. It's Archie Kotam, born in March 2018. I'm going to move a bit faster. Follows with MAPCAs, hypoplastic native, right and the left PA. The distal PA is right-sided aortic arch, aberrant left subclavian. It's pretty much getting on to the full house now in complexity. So category C of the anatomy for pulmonary atresia VSD physiology. So how does this patient move forward? Gets an RVOT stent, balloon dilatation of RVOT stent and a left PA in August. So by then, how old is this child? Was born in March, so it's 5-6 month old. Unifocalization of MAPCAs, 5 millimeter fenestrated VSD closure, fenestrated ASD closure, 12 millimeter RV2PA contegra, homograph augmentation of PA. So again, pretty challenging surgery, and it did give us grief. Further, we'll look into it. And this patient further into this January needed cardiac catheter and dilatation of the PAs as well. So let's talk more about this one. Post unifocalization, this patient stayed in ICU for 35 days. But this is complex end of the patient and a complex surgery, fenestrated ASD and a VSD closure as well, and establishment of the pulmonary tree. So what problem? I've just headlined few things. We'll talk about it. Rhythm issues, commonly junctional ectopic tachycardia, nothing, no surprise. These patients are prone. Follows physiology. You've operated on a VSD and you've done a fenestrated VSD closure. These patients are predisposed at high risk of JET and management of JET. Delayed chest closure, hypoxia, again gone on to nitric oxide, cardiac catheter on day 12, moved forward, but we knew that there were small distal pulmonary arteries which are not amenable to surgery. You can only go till the till you can approach and you can see what happened. Arborization inside the lung parenchyma is not amenable. This RV was hypertensive, so this is going on to the extreme end, bad spectrum of pulmonary atresia VSD. Airway Malaysia, so that comes to ICU part when we come to move forward. I've put down this patient is known to have DiGeorge syndrome. So a little more about these. Whenever you have pulmonary atresia VSD with no native PA and a lot of circulation is dependent upon the MAPCAs. In these group, it won't be a surprise. Nearly half of these patients may be with the catch-22 syndrome, DiGeorge syndrome. So they are associated with hypocalcemia, airway Malaysia, so they go hand in hand. And this is multi-system disorder rather than only one system disorder that becomes a problem. Acute kidney injury, renal replacement therapy with the PD, with the diastolic dysfunction, RV hypertrophy, infection, MRSA colonization. You've stayed in ICU for 35 days. So you've been playing with fire for a while. You can, to an extent, you can prevent, but you cannot avoid it completely. So this part was about these complex patients with a complex anatomy who are going for a full repair. Even if we do it fenestrated ASD and a VSD closure, when your RV is still hypertensive and you have done everything to kind of have a pop-up wall and everything for this one, still their recovery in a post-operative period with the RV hypertrophy will be slow, will be associated with a lot of problems. Okay. Moving on. This is my next patient is Lincoln. Lincoln was born in December 13. Again, full house. So we've had more things, dextrocardia, CCTG, VSD, PA, LPA, stenosis. To me, as an intensivist, this is still a physiology of a VSD with pulmonary atresia, but with a lot of added things around it. And it will be a huge headache for a cardiac surgeon and cardiologist when you're following up thing with all problems. I put this patient into this category, giving more complexity to the picture. What interventions did we do for Lincoln? He had a right modified BT shunt. He needed ECMO support. Again, I hate BT shunts, not good. For intensivists, they are bad. Needed ECMO support. Post BT shunt, ECPR, made good progress, then had a right cavopulmonary shunt, enlargement of LPA. RMBT shunt was taken down. And then in November 18, so by this time he's now nearly 5 years old. He had a 1.5 ventricle repair with the complex surgical, which you can read it there. So at this, in these patients with this complex anatomy, knowing the physiology, pathophysiology, the blood flow, circulation, and how my ventilation is going to affect which part of the ventricle or which part of heart, and moving them forward, and what saturations to accept will be very important. And that's where we need to kind of have a clarity of picture between intensive cardiologist and cardiac surgeon. So this patient tells us about these patient spectrum of patients who would have not a full 2 biventricular repair, but 1.5 ventricular repair, which may remain like this or move forward. This patient had a ultimately proved to be a complete heart block, which we were trying to avoid to put a pacing wires, but needed a dual chamber pacing. So Lincoln was my kind of a flavor was about how complex the anatomy is and how complex the surgical intervention and ongoing management can be. Last follow-up in November 19 is nearly 6 years old now. Is 21 kilos, 116 centimeter. No family concerns or cardiology comment from the summary, and he's on 6 monthly follow-up. So if you see this complexity, if the pulmonary vessels we are able to manage it, obviously this patient is going to need further intervention. But at 6 years of age, he's doing pretty well. Next patient, I think this is more. This is Hannah Storer. Consultants would know these patients. I've kind of more studied these patients. So Hannah pulmonary atresia, disconnected LPA and VSD, and I have just listed how many interventions, and I've not listed all of them. Cardiac catheter interventions, diagnostic intervention there, and also cardiac surgical operations which have been done, starting with a central shunt, clot removal, PA reconstruction, and then full repair. Sorry.
Anand, this Hannah Storer, when she was first born, branch pulmonary arteries, if they were there, they were thread-like. So there was a point where there was consideration that we were going to limit care, but parents were very adamant, and they persevered.
Wow. So she's done, obviously you can see how many interventions, but
remarkably well, considering the initial diagnosis.
Yeah. So I was just studying this thing, and I didn't know that would have been a picture, but well, I'm seeing it from the other end. I'm not following this patient from prospectively. I'm seeing it retrospectively. But this patient is doing very well. Last follow-up was in September. Are you following this patient, Joyce? So this patient was seen at end of last year, and is 12 years old.
I think it's either AD or shocks patient. So, but I know her well because I remember her in ICU bed 5 when we were in the old hospital.
Okay. That means the whole team has spent a lot time bedside thinking about her. But I was very pleasantly kind of surprised and relieved that this patient at 12 years of age is swimming, is cycling in south of France, and as all the teenagers are, reluctant but still managing to do PE. I think that's a fantastic result. A very complex patient and has done very well with those interventions. Okay, I think I'm overrunning my time as always, but let's go. So this is Alec Jones, who was born in June 03. So another patient who has 22q deletion. Okay, multiple intervention done. Staged one, obviously, at birth or first neonatal period, BT shunt, Rastelli procedure, and reduced anatomy and replacement of RB2 per conduit. Last follow-up a couple of years ago, he's 16, so he's nearly moving out into a transitional care now, and he's 50 kilos, and he's saturating well, and he's doing well. So, and he's also 22q deletion. Obviously, it's a spectrum, but patient who we are following up now, we are coming up to nearly 18 years of follow-up for these patients now. I think this patient, just I've written that just that I forgot this patient's name. I think this is Yasin. Okay, let's move on from name. So this patient born in December 12, atresia VSD, and this is the pathway. This is how this patient has moved forward. So right modified BT shunt and then a PDA stent to the left pulmonary artery. I thought that was fairly fascinating to have right-sided BT shunt and a left-sided QP being enhanced with the PDA stent being put in. And then after 10 years, so by the time this patient is 12 years of age, he gets a Rastelli procedure done, has further cardiac interventions, and then is doing pretty well. I've written the last follow-up. I made a mistake somewhere. No, it's 6 years, nearly 7 years old now, and he's doing pretty well. Does anybody know this patient, Yasir? No. I thought this was very interesting, that how to augment the pulmonary blood flow, not only VT shunt but also with a PDA stent. Coming up to kind of closure of these things, this is the NICOR data which shows pulmonary atresia VSD. Obviously, it's not very clean and thing because each patient is different, but this is where we are. I think we are doing 7 cases as opposed to Birmingham, we're doing 17 patients, but pretty good results. So we're doing well at a national level. I don't know the international things. Condition. Oh, sorry. Let's go back. So I thought this is kind of coming up to closure. I thought there are themes in managing these patients at the different stages with different anatomy and interventions. In neonatal period, you will be balancing the circulation, making sure there is adequate but not overzealous pulmonary blood flow. When there is a correction of full correction, which may be with or without VSD fenestration, then you will have a problem with this RV dysfunction. With pulmonary QP, pulmonary vasculature and arborization, RV pressures are very high, and these patients become very challenging to manage and move forward with them. Even if you do a fenestration and there is a blow off and there is a mixing of blood, so pressure kind of is limited in a way, we will have a effect of the right-sided heart failure onto the whole system in circulation, which may be because additional factor would be you will be doing a ventriculotomy, tunneling in a VSD closure, hypertrophic stiff RV with a diastolic dysfunction, right to left shunting with an anatomical or a high PVR setup. So where we have to accept that, okay, we have to accept a lower saturation at the expense of to have a good systemic blood flow. And that has to be, again, collaborating, understanding how much is the RV pressure, how much is the shunting, where is the shunting. All these things, dependence of the right ventricle and the left ventricle and interdependence will lead to ultimate systemic cardiac output will be low cardiac output state. Right-sided failure, high venous pressure, which will lead to kind of a poor kidney perfusion, AKI. There can be concerns about the chylothorax. When you're operating on a VSD, you may have challenges with the rhythm issues. Last heading for me is a restrictive RV physiology. I think I didn't attend that session, but you guys may have spoken about hypertrophic restrictive RV physiology. So diastolic dysfunction. Systolic function is fantastic. Intensivist is not interested in that, but it is more diastolic dysfunction, loss of RV compliance. There is effect of bypass. And then there is a prosthetic material which will be there for a VSD closure or a transannular patch. They don't have a compliance, so you have a more restrictive physiology. Clinically, you see low cardiac output state, you have a fluid responsive circulation there, but a large liver, high CVP, and then pleural effusions and a PD losses. And that's why these patients with the diastolic dysfunction, RV diastolic dysfunction, would keep the chest drains in place for a prolonged period of time. And commonly, these patients go to ward with chest drains in place. So that's all part of the high right-sided pressures. Echocardiographic, how would you diagnose it? Clinically, we will see those things. We'll have echocardiogram. You may have a classical signs on a echo, but ultimately this RV becomes so big, so muscular, and that becomes a passage just for a blood to go, and ineffective passage rather than contributing to the right-sided output. What can we do about this? What are the treatment options available for us? Right-sided lesions are much better to be self-ventilating, so early extubation, spontaneous breathing will be good, though that is ideal when the patient's cardiac output is low and the patient is on inotropic support and needing a lot of filling. That point cannot be reached, and in that situation, try and minimize the effects of positive pressure ventilation. So give a short I time, inspiratory time, give the lowest mean airway pressure. So try and balance it out so that we give best pathophysiological setup for right side. Avoid tachycardia. You have rhythm issues in these patients. Try and maintain AV synchrony. So atrial ventricular pacing wires, if they are there, use them. reduce catecholamine, use milrinone. So inodilator, lysitropic effect, use milrinone, friend of a fellow's physiology post-operatively. These patients are very volume responsive. Keep on. So there will be a phase where you need to keep on giving volume, continue milrinone, and give time for this RV to kind of settle down a bit. That's me done. Is that okay? Any questions?
Anand, it's Arul here.
Sorry?
It's Arul here. Arul.
Hi, Arul.
Yeah, it was an excellent talk of this complex anatomy. So the only thing which I will add is in block to shunt. Mostly, I mean, a lot of time it will be either partially or near a block shunt. So what we sometimes do is take them to the cath lab and then put the catheter near the mouth of the shunt and then inject the anticoagulation straight in there. Otherwise, sometimes we can put a wire and either balloon it, even the stent that PT shunts. These are all the options you can consider. So.
Oh yeah, that's very good actually. Yeah. You could do that one. Yeah. Hey, thanks, Anand. Yeah.
Anand, can you change your ICU protocol? That don't call surgeon, call Arul first. Yeah.
call all both of us. That's what I meant.
No, I think the take home from an intensivist point of view is thinking about it, diagnosing, highlighting that one, and knowing your intensivist limitation that you are not going to fix this one. You need help. So you're right. Actually, I didn't put that one interventionist because we could definitely do that one. Highlighting and getting the patient towards theater is very important. Don't waste time. I'll do this. I'll do that. No. If you're worried about it, highlight it, work on it, make sure that, okay, you're happy with the QP and then you can work around it. As an intensivist, we think about the worst case scenario first and we work backwards. Yeah.
Let's say we have got a patient with overcirculation admitted to ICU. What can you do conservatively to manage overcirculation with MAPCAs? What inotropic support will you use? Because it will have left heart overloading and
so
affect you as well with overcirculating.
So let me get this question right. That you have a patient who is overcirculating.
Can I
want to restrict it and assess it? Yeah.
Can I clarify? So we've got pulmonary arteries and MAPCAs. So different structures by nature and different response for inotropics.
Yeah.
That's why I'm asking.
So I would have two ways. I think you said about inotropy and things. So I would work around with two headings. One is a ventilation. So I would try and get control of ventilation first. Sedate muscle relax, get the CO2 up. So pulmonary vascular resistance goes up. So if there is I would call it delta, the pulmonary vascular resistance and a systemic pressure. If the delta is less, then there is less blood going into the lungs. So that we can do. And putting in squeeze or a significant inotropic support in these patients is going to be even worse, because then you are moving the systolic pressure up, systemic systolic pressure up, and then there will be a lot of downflow towards lungs. So in those situations, again, these are complex situations, because if there is a room and diastolic blood pressure is reasonable one, I would love to use just milrinone and ventilate and try and use. You could use think in terms of using a dilator, vasodilator in these patients. But most of the times where anatomically there is a lot of blood rushing down into lungs, we struggle with the low blood pressure, low systemic circulation, concerns with the gut perfusion. And in those situations, we don't have room to give inodilator. Does that answer your question? But I would avoid vasoconstrictors. That would be my first thing.
If you need to maintain your blood pressure, would you give just volume or any?
Volume becomes a first part to just try and keep the organ system perfusing. But there is a limit to what you can do. In a post-operative period, when I know that it's a transient phase and patient would settle down, systemic inflammatory response and thing. For example, a BT shunt, I would just use volume to start with for 24, 48 hours, stabilize another 48 hours. And then by day 6, I'm diuresing this patient. But if there is a situation where I put a BT shunt and then there are MAPCAs which are giving me a problem, I could use volume to start with. But then we will have to have a sit-down chat saying, hey, is this physiology manageable with medical treatment, or we need to intervene surgically. But you're right, fluid becomes first, second becomes inodilator, compromise becomes a bit of a inotropy. We should avoid a vasoconstrictor and we should control ventilation and CO2.
And what surgical options for this case if we can't manage in ICU? It's a question to surgeons.
Yeah, so this is question more, I'm a listener here, yeah.
French patient in ICU or neonate.
Means depends upon the condition. Is it a PT shunt you're talking about, or a PD stent you're talking about, or
just VSD MAPCAs?
No, I don't think MAPCAs are natural. They don't over circulate unless you've added a shunt or something. I've never seen a pulmonary arterial MAPCAs alone over circulating and doing something. Unless there are MAPCAs and then you added a shunt, that may be an issue.
That may be an issue. Yeah.
Has anybody seen natural pulmonary arterial MAPCAs over circulating?
No, I agree with you, Ram. Actually, I think the problem is when you start to have MAPCAs on one lung and then all pulmonary arteries to another. You put a BT shunt, and then they start to, one thing that I've done actually in the past was to, there was a huge MAPCAs on the left, and I'd done a partial PA band of the MAPCAs, so to restrict that because it was in that condition. So you had a shunt on one side, huge MAPCAs on the other, and the only way out actually was to try to limit a little bit the pulmonary blood flow. But these are the complex one actually, especially when they are small, and especially when the PVRs are changing, around 2-3 months of age. PVRs are all over the place. You never know if you have to do a shunt with a bypass, then upset the PVRs even further. So they're very, very challenging. One thing actually that I wanted to make a comment actually is on the management of BT shunt in the first 24-48 hours in relation to heparin. It is recognized that, the problem with blockage, it could be either a mechanical problem, so the stitching are not good, or a problem actually with kinking, and the problem with the patient can be most of the time they are hypercoagulability because they have cyanosis and they have a lot of platelets and stuff like that. So I tend actually to ask for a higher heparin because I think the usual 10 units of heparin in my mind, the first 24-48 hours don't do much. And I don't know what other people actually think about it, but in the first 24 hours at least, I'll always ask for a higher heparin and maybe measuring the ACT by the bedside because you can titrate it much quicker and much easier. Because in reality, it's there. I think it's in the first 24-48 hours that the shunt will declare itself if it's working or if it might need revision. It's very rare. To be fair, actually, in the last 5 years at Alder Hey, we have revised very, very little shunts. Actually, to be fair, I don't remember actually really, probably one. But that is what I'm worried actually, that in the first as soon as they come back from theater, they might start to create some clots because of their pre-op status.
I'm glad actually you asked this thing because historically and in the unit we are used to going on to either a prophylactic heparin, that 10 units, or going on to therapeutic heparin and going on to APDT management between 60 and 80. So that has been a standard practice for whenever we're giving heparin. And that's why I see your point of ACT, which is a bedside test, and you can titrate it very quickly, in a way. We may have, just as a group, we may have to discuss what's the best way forward to manage these situations, especially in an immediate post-operative period. Once the bleeding is settled down, I think what we tend to do, or in speaking with you guys, is to go for APTT management, which may be kind of a delay of around 60 minutes, maybe 1 hour or 2 hours to get it right. But if you want to think about ACT, we are very used to with ECMO and
absolutely. That's why I like it, because all the nurses are used to it. the machines are there available, and it gives you a titration that is really quick, and you can act immediately.
I think that may be a good point for us to kind of talk about it together, because that will be, though it doesn't seem, but a reasonable big thing for. We should change our protocol. We'll talk about it, discussion to review the practice. But that's a good point. Yeah.
Yes, sir. Yes, certainly. I also agree with you, because I've dealt with a couple of times blocked shunt and the way the babies behave. So the first 24 hours, it's better to have a high ACT. Once things settle down, then we can go on to the prophylactic 10 units of heparin. That's something which we can consider, and we can do a short audit or something, and we can plan.
Yeah. I think it will be good to kind of review, sit down and write down things, and then it becomes a change of practice and learning in a way.
True. Yeah.
But just to make a comment actually on the shunts, as we are on the topic actually, and Arul is there. He made a very good point actually of the help that they can give. And I had a patient actually where, because of the anatomy, it seems actually quite similar to a patient that you discussed the other day with a shunt that is really close to the aortic wall. And the aortic wall, in reality, the curvature of the aorta, when the pressure was going up, was pushing the shunt and creating an obstruction in the belly of the shunt by the aortic curvature. And the only way out actually was to stent the shunt, and that actually sorted the problem out. So I think actually that it's easy for a surgeon to say, "Oh yeah, go back to theater." And I took that patient back to theater just to realize that there was nothing I could do, because there was nothing, nowhere else I could have put my my shunt. And very difficult scenario. But the obviously you can do a little about orthopexy, you can do things like that. But stenting the shunt, I think it's an option, and it's working. I was talking with people working with Mark Gwelling, and is a Belgium interventionist. I don't know, Arul, if you know him.
Yeah, I know him.
Yeah, so that's why actually sometimes I propose actually for you guys to stent the shunt, because he has produced a few papers on that. And also in Melbourne, actually, they construct the shunt in a way that they can be stented. And by that experience, you increase the shunt size to 1 millimeter.
Yeah.
And bring in patients, instead of having upsized shunts, you can do it like that. And I think actually that I've noticed a little bit of reluctancy at All the Hay to do that, but maybe it's something that you guys want to explore, because I think actually that 2 cases presented, I think on Monday, they could have had actually a stenting of the BT shunt. In my view, actually, in my experience and my view. Now, everyone actually obviously can think differently.
True. We will look into it, and then we can even contact Mark Welling, and he's very, very senior and very good interventionalist. We can get some help from him, and then we can take to the next level. Yes, sure.
Yeah.
Hey, Arul, quick question on the same line. Does it make a difference in terms of timing a very fresh shunt, like 36 hours old shunt, as opposed to 6-week shunt? Your approach would be very similar to go to cath lab and assess if there is time. Yeah.
Yes. Yeah.
Okay. Thanks. Yeah.
I mean, a couple of times I've done that, and it is given a very good result.
Okay. It does make sense actually. I think I'm glad. Yeah, this is good. Yeah, I like it. Yeah.
Sure. Okay.
Thank you, Anand.
Thank you, mate.
Thank you very much, guys.
Thank you.
Anand, last question. You touched the topic about volume replacement in tetralogy, and we all know that in restrictive physiologies, volume replacement is very important. I just had a series of 2-3 questions. One is, what parameter do we follow when we do volume replacement for these kids? I mean, what is the driving force for for deciding how much volume does the kid need. Second is, at what point of time do we think of adding an inotrope to supplement the advantages, the effect of volume replacement, which we want, as in increase the pressures or increase inotropy. And third is, what is the choice of inotropes which you guys follow? I mean,
okay.
will be your first option, which will be your second option, and then, yeah, thanks.
Yeah. So I think this is a holy grail in managing these patients. Commonly, what we would do is bedside assessment and a CVP assessment, and see what sort of a CVP target. And you may be part of it. You may have seen that one is speaking to even a cardiac anesthetist. Is what sort of a CVP were you targeting, and with which, what was the blood pressure? So, and then I tend to give a fluid bolus and get the CVP up, see the effect, and then still try and give more fluid. But at some point, you will see that, at this point, after CVP of 18, actually, it's not making a huge difference, So that would be a bedside clinical assessment of CVP. What is the liver size? What is happening? And what is the effect of what is happening with the systolic perfusion? Does that make sense? So there's no point in having super number of systolic or systemic blood pressure, but when rest of the things look pretty good. So if the lactate is okay, child is warm and well perfused, child may not pass urine, because in these patients, I will have a peritoneal dialysis catheter. So in that situation, I would even say that, hey, even if I don't get the number of the blood pressure which I want, but if patient's systemic circulation is happy and I'm able to support the kidneys with a PD, then I move my target, the systemic blood pressure target, a bit low, and balance it out how much fluid I want to give. Does that make sense?
Yes, yes.
I tend to stick to giving a bolus, but as we all are, we are different people, and somebody may use a background infusion of fluid and then do that one. And sometimes that works better in an early phase when you're just giving fluid. I like to have an assessment, but that means you are bedside pretty much all the time and doing assessment. Once you put in background infusion on, which I've not seen in other places, to be honest, a lot, but sometimes that can work, and I would leave it to the bedside person who decides that one. That's how I would go by fluid. If I have in these patients, if I can use a blood product for a correction of numbers, I would easily use some good volume rather than neonate. We use a HAS. After that, we use Jello, a colloid, to do that one. That's about fluid. I tend to, if I have to give repeated fluid boluses, then I go on to a vasoconstriction. I get an echo done, making sure that I'm not missing something sinister, and it is to do with the vasoplasia or requirement of the vascular volume which is needed. Then I immediately go on to vasoconstrictor of choice. It could be NORAD or it could be vasopressin. Neonate, it could be vasopressin, may be better because of the PVR effect is a bit less. But for that one, I would rather get an echo done, making sure that the contractility is good and it's not the cardiac contractility which is affecting my cardiac output. If the function is good, then we will, as a tradition, we've always used to order AAP ICU to have a bit of dopamine. And many patients, dopamine works very well. Few patients, it may be better to just give low dose adrenaline rather than giving dopamine. And you have to balance it out with what other things are happening in terms of jet. So that's the approach with supporting the post bypass contractility and a systolic function of ventricle, as opposed to a vasoconstrictor and needing less. You don't want the child to be super edematous within first 36 hours and you're not using a vasoconstrictor. No, that's not the right thing to do. So my approach usually is like by the third fluid bolus or the fourth fluid bolus, 10 mil per kilo, and I've got an echo done within first 2-3 hours post-operatively and function is happy. Then I would switch, put a vasoconstrictor of choice on, even in that early phase. And sometimes patients come back because that phase has been done by an anesthetist in theater. Then by the time patient comes to us, he's already on a vasoconstrictor. Then you may say that I don't have enough effect with only one agent, then I use 2 agents. But then we are talking about a very sick patient who is sedated, muscle relaxed, temperature cooled, cardiac output is maximized, is on peritoneal dialysis. Does that make sense? So then you're talking about the third agent and the fourth kind of in total vasoactive agent. Okay? Does that answer your fluid, an inotropic agent, and a vasoconstrictor answer? But my usual expectation is I give myself for a sick, difficult shunt patient, BT shunt patient or thing, I give 2 days for filling, 2 days of stabilization, and then 2 days of diuresis. That's, you cannot put time figures, but I tell myself that there is a filling phase, there is stabilizing phase, and there is a diuresis phase.
Okay. Anj?
Yes, Atile. Yes.
Hi, Anj.
Hi.
One comment actually that I have on BT shunts actually, because I think actually both myself, Rafael, and Ram have seen the changes from BT shunt in thoracotomy to BT shunt in sternotomy. And in the old days, actually, there are a few considerations that for you guys that you need to take into account. The first actually is that I have rarely seen patients over circulating with BT shunt in thoracotomy in the old days, and one of the reasons actually is what in those days they used to do patients that were not neonate but a little bit older. And second, actually, when you are in thoracotomy, especially in the right thoracotomy, you position your shunt much farther down into the subclavian artery, and also in the pulmonary artery, you are really, you're really at the level of the first branch. And in fact, actually, if you go and look back actually at the CT scans done in these patients, most of the time the right upper low branch after a BT shunt in the right thoracotomy, it's gone. So since the experience of Norwood, I think actually everywhere we started to appreciate more to do shunts in smaller children, but because of the possible instabilities, doing them in sternotomy because the potential need for bypass. And I think actually that you need to appreciate two things actually, that when you do a BT shunt in bypass, your PVRs go all over the place. The lungs start to get not as compliant as because there are leukocytes that are accumulating and so on and so forth, inflammatory reaction and all of that. And then your shunt actually, it's a little bit more central. It's a little bit more on the innominate artery, passage between innominate artery to subclavian artery, then really the subclavian artery, maintaining more or less the same size of a 3.5 shunt. So as a surgeon, actually, when you notice over circulation when you are between theater and the first 12 hours, 24 hours, you really need actually to think actually, is there anything that I can surgically do to help this patient out in order not to over circulate? That's why I think actually we have all adopted the strategy, and I think actually I would encourage actually all the young surgeons not to to encourage to use the chest open technique and access the shunt and maybe put in a clip or maybe put a little wrap around it and that kind of stuff, because what the pharmacology can help, it's never as good as balancing your QPQS mechanically, restricting the shunt. So they can actually do everything. So you have to think about what can I do for this patient that can actually take out of this initial phase of PVRs all over the place. So maybe start some nitric, so you abolish the PVR swinging. Maybe you restrict a little bit the shunt, you leave the chest open and you reassess. Then you start with a high heparin because with a little clip, you don't want the shunt to clot. You put up your heparin and you fill the patient rightly with the right level of hemoglobin. And then you reassess and you work very closely together with the intensivist and the cardiologist. So in a patient that are over circulating and you are worried, actually the three people need to be at the bedside: the cardiologist, yourself, and the intensivist, because pharmacological or physiological manipulations are short-lived. First, because the patient First, because the patient will adapt to that, like CO2, high CO2 or high inotrope support.
Yes.
And then because you cannot carry on forever with that.
Yeah.
So you need to find out, you know what I mean, what you can think actually, how can I help this patient to get through the first 24, 48 hours so everything stabilizes. And then, and I think we, you know, the recent case that we have done actually that was in extremes in the morning, I took him for a BT shunt, I've done a 4 millimeter BT shunt, restricted a little bit, reduced the inotropic. I think actually, I don't remember his name, but Rames just disconnected the PA and released the PA band.
Yeah.
So that is a typical example of how, you know, complex cases like that change the physiology through time.
Yeah.
So just actually, you know, to the young guys, you know, starting a consultant, you know, these are the challenging cases.
Yeah.
But I think I wouldn't go back to do right BT shunt through a thoracotomy because I think actually the amount of, and now I'm touching wood, the amount of blockage of BT shunt is much less through a sternotomy than through a thoracotomy. You need to do a lot as well. You need to do a lot of BT shunt in thoracotomy to get them right, because it's I've done a few at the very beginning when I was in Birmingham and then subsequently, but I don't particularly enjoy it.
Yeah. Thanks, Atilu. Actually, that highlights one thing which, from this ICU perspective, that we need to be a lot more alert, awake than a BT shunt or any shunt on bypass and off bypass. So when you have gone on to bypass, there is a lot of background reason why you've gone on to bypass, and then the effects of bypass. So those patients, as an intensivist, we would look at it very differently. You know, that anticipate trouble, anticipate a behavior, a little bit odd behavior from these patients. So, but that starts from pre-operative, the course of patient, and what has pushed us to do these things. So yeah, that's another good point. Yeah, cheers.
Actually, on Ram, and it's Rafael around as well. I was just wondering, from this discussion today, do you think it'd be worthwhile, or it's already been done, looking at our BT shunts, RVOT stents, and PDA stenting over the last 5-10 years?
For what?
Just to see how we're managing them, how much problems we are having with them, or not, whether one is causing more problems than the other.
No, well, it'll be good, interesting. So I think around 2014, 2015, we reviewed all the BT shunts and then presented.
Yeah. But what about
PDA stenting has started only since probably 2012, 2013.
No, I think PDA stenting much later, maybe 15, 16.
When did shock start? 13,
I think it's 15, 16. I don't think it was that early.
Okay, so that is one thing, and the second thing is RVOT stents, very few number.
Yeah, I know. But what I think would be useful for the registrars, if they are keen, is to look at, as Attilio says, you know, that the preference now is to go via midline sternotomy for BT shunt if you do any. And I realize that we are doing less BT shunts now than what we have been doing 5-10 years ago.
That's correct.
Just for them to sort of understand, yes, you know, it's very, very, very interesting what Anand has provided us with, you know, a snapshot of the spectrum of all the possible problems or not, or issues in ICU. But it'd be useful for them learning from this event now, this teaching today, as in looking at how varied our management has been in terms of, you know, of the problems that have arisen, and what we can then sort of learn from it for the future.
I think Joyce, it's a good point actually. I can see actually that I probably joined all the hay at the time that Shock was starting to do PD stents, and I remember actually that I came to the BCCA organized, I think it was in Manchester. And
Manchester,
I think
would be 2015, I think. Yeah, or 14.
Yeah. One of the two actually was in Manchester, and Rafael presented the data on the on the BT shunts and this and that, and how many we do. There is no doubt actually that we do much less BT shunt because we do early repair, because intervention. And I think actually that, as usual, actually when you introduce a new technology or a new intervention, you start to be very enthusiastic, otherwise you wouldn't introduce it, and then you do it to everyone, and then you understand actually more about which are the group of patients that need that. I've done a tetralogy of Fallot the other day, which had a PDA stent put just few months before. I think was probably 4 or 5 months before, and was not all of that bad actually, but it was in the way, I mean, so we had to remove the stent. We have to consider if to enlarge the LPA or not. The LPA hasn't grown as much, So I think actually we are still in that phase of learning all the facets of patients, and there is no doubt actually that now we have few interventions that we can throw to a patient, but we need to maybe be a little bit more consistent with the indication for each one. But I think we are getting there actually. So it could be a good way to see actually, all of the duct dependent or systemic to pulmonary artery dependent circulation, to see if we can draw some more conclusion in any of your registrars who wants to embark in that. We support
because
it.
I mean, if we can get something out of something also useful or beneficial out of these sort of Wednesday morning teachings, and then then they can present it again in a few months' time, saying, all right, as a result of Anand and other people's work, we have looked at it. This is our trust's outcome. This is what we would like to do or not do, and I think it's just to stimulate interest, isn't it?
Oh, absolutely. No, I think it's a good point. I think actually Raphael went to a meeting actually recently, and someone big in intervention was presenting the sort of indication for each cases, and now we know actually that, because we have been there as well, that if there is a big tortuous duct that is landing on the LPA, that means actually doing a BT shunt plus PA reconstruction versus stenting of the shunt versus stenting of the RVOT versus a Sano shunt. So we have actually all of those interventions that we can think about, and there is no doubt that the stent in the duct actually it's the least favorable one that we as a group actually are going to put a patient through, because we know that we have been there. You see, when there are problems to that LPA, then we go and have a stent in it. So, I think actually if one of your registrars want to embark in that we will support it actually by no, yeah.
Well, I could sort of get the list of patients together, and then you could get registrars doing different things. Some of yours, maybe 1 or 2 of your surgical registrars doing the BT shunt side of things, and then 1 or 2 of ours doing either a PDA stent plus the RVOT stenting ones.
Yeah.
Thanks for that, Joyce. It's a good idea. We need to go to theater, so Anand,
sorry.
Anand, thank you very much.
No, thanks.
It's been excellent.
Thank you very much, Anand. It's a good review of all the patients that you have seen over the years. It's very interesting.
Yeah, no. I enjoyed it actually. I really like that. So this
very good. Well done, Anand. Thank you.
Thank you.
Thanks, guys.
Thank you. Bye.
Oleg.
Oleg is gone to theater.
Oleg is gone. Okay.
Is he going to theater? Okay, I'll stand down. Thanks.
I need to go, but I don't know how to start.
Go to the dots, the 3 dots.
Where are the 3 dots?
On that. Okay. Is it in there?
Stop record.